All right, here we go. He's a good guy. Yeah, I feel sorry for the online EMT students that have to because that's why I'm recording these, right? Because I'm building an online program. They have to download these and listen to them. There's going to be 6 of the one chapter. So there's a 20-minute download and another 20-minute download. You might as well listen to one while you're downloading the other one. All right, so musculoskeletal system. The nice thing is, for the most part, this is trauma, right? Medical diseases in this system are pretty rare. Okay? Normally, when we're with the musculoskeletal system, we're talking about trauma stuff. Okay? The questions to ask, though, prior injuries. One question, and I wish this was on every single slide. This needs to be a question you ask anybody you're worried about brain issues, anybody you're worried about musculoskeletal issues. Are you on any blood thinning medication? Okay? And then determine if a medical problem caused the traumatic injury. What that means is, did you have a heart attack and then fall off the roof and break your legs? Right? Did you have a seizure and then wreck your car? Make sense? You can have a trauma that leads to a medical. You can have a medical that leads to a trauma. Right? The fire captain just a couple months ago that died, he went on a call that involved his daughter. His daughter was not injured critically, but the stress of the call caused him to have a heart attack and die at the hospital. Right? You wreck your car, and that puts enough stress because of adrenaline that causes you to MI, causes you to have a stroke or whatever. So you can have a medical that leads to a trauma. You can have a trauma that leads to a medical. Make sense? So the word I want you to get used to, 2 words on this slide. Deformity, meaning what? Not straight. Right? Or abnormally bent. The other word is crepitation. This is the bone-on-bone grinding. Okay? It's real cool until you feel it. And then you go, bleh. Right? So one thing you feel, and you're like, oh my God, stop moving your arm. Right? So you're going to look at signs of injury such as deformity. You're going to palpate it. You're going to look to see if it's symmetrical. You're going to listen or feel for crepitation. And we're going to talk about head-to-toe assessments here in about 68 slides, which could take till tomorrow. Thank God you don't have class. 10 o'clock, we're going home. Told you this slide was brutal. Make sense? So look for injury such as deformity. Palpate it. Is it symmetrical on the other side? Is there bone-on-bone grinding, which the only way you can find it is to actually feel. And then you're going to do a head-to-toe assessment, which we're going to talk about those parameters here in a second. Minutes. Shut up. Oh my God, it's a miracle. We got to the secondary assessment of the medical patient. Okay? So this is the medical patient. Okay? That was just the body systems, 28 slides. So responsive medical patients is easy. You just focus on what they tell you. Okay? Hi, I'm Sean Pitts, Deer Park Ambulance. What's going on? I'm having chest pain. Boom, problem solved. Right? Now, if they're unresponsive, we treat them a lot like a trauma patient. Trauma, you have to find what's going on because they don't necessarily have the ability to tell you in trauma. In unresponsive, they have no way to tell you. So you have to take in all these pieces and build an idea of what's going on. Make sense? So awake patients, you look at their chief complaint. Unresponsive patient, you're going to look at their physical findings. We're going to break these down in the next 48 slides or so. I made that up, probably closer to 80. Anthony's like, I hate this class. Don't you wish this wasn't a day you were on shift so you were getting paid to be here? I am. Shut up. Why are you not wearing your uniform? Aren't you supposed to wear your uniform if you're here? No. You sure? I'll make a phone call and check. I will. I know his phone number on my cell phone. I can just text him. All right. So responsive medical patients. You're going to take a history of present illness. You're going to take a history of what's going on right now. You're going to take a past medical history. You're going to do some sort of physical exam. Every single one we just went over had a physical component, right? Okay? You're going to get baseline vital signs, and you're going to do some sort of intervention, and you're going to transport them. Now, do you think every single patient has an intervention that you can do? You don't think so? All for one and one for you're on your own. So, position of comfort, would that be an intervention? Could be, right? Maybe that fixes the problem. You give them oxygen, that's an intervention, right? Does that make sense? So, most patients, you're going to have some sort of, here's what I'm going to do for you, right? If not, lie to them so they feel like you're doing something. I'm kidding. Kind of, what? The whiskey in my ambulance is for me and my partner only. Okay? That's easy. So, responsive, present illness, medical history, physical exam, baseline vitals, intervention, and transport. Okay? Somewhere on your note sheet, I want you to write the word vomit. V-I-V-O, holy crap, V-O-I-M-T. That's the last day I don't drink coffee. V-O-M-I-T. Holy crap. That's it. Give my coffee cup back now. It's not worth it. Woo. Yeah, all of them. Okay? The word vomit stands for vitals, oxygen, monitor, I has two meanings, interventions, and interrogate. I'll go over and get my product. T is treat and transport. I'll say it again. V for vitals, O for oxygen, M for monitor, I is interventions and interrogate, not like waterboarding and bamboo shoots. Okay. T is treat and transport. At the end of every single scenario in this class, you are nervous enough that you want to vomit, right? Which means at the end of your scenario, when they say, are you done, you're going to say, nope, and you're going to walk through vomit. Did I take vitals? Did I give them oxygen? Did I monitor them, like general impression? Did I do interventions? Did I interrogate them, meaning did you ask questions? Did you treat and did you verbalize transport? Okay? And then you can say, yes, I'm done. Vitals, oxygen, monitor, interrogate, interventions, treat, and transport. If you think about vomit is pretty much all of the points on that skill sheet related to vitals, oxygen, monitor, interrogate, interventions, treat, and transport. Okay? I will tell you that single-handedly allowed me to pass my skills in my advanced EMT class. You move on to advanced EMT, it's vitals, oxygen, monitor, IV, treat, and transport. At paramedic, vitals, oxygen, monitor, interventions, IV, treat, and transport. Right? That vomit will never leave you, I promise. Right? Unless you're sick and then it leaves you pretty willingly. Okay? So we're going to break these down one by one. Take a history of the present illness. If they're conscious, take it from the patient. If they're conscious but not responsive or not oriented, ask family or bystanders. Ask questions like, what seems to be going on today? Oh, you're telling me you're having chest pain. What does that pain feel like to you? That's an open-ended question. The question, are you having chest pain, is not open-ended. Right? That's easy. If you ask specifics, you lead them to what you want them to say. Make sense? Chief complaint. We talked about this before, right? Why patient activated EMS? The most common thing that we do is we write in chief complaint in our reports things like chief complaint, cardiac arrest. Right? We do that, but the true definition is what the patient told you. Your dead person does not say, I'm in cardiac arrest. I wish they would every once in a while. Right? It'd be kind of fun. Once or twice. If they say, I'm having chest pain and shortness of breath, you say, which one of those is bothering you the most right now? We'll get to the other one, but what's the most concerning thing to you? Make sense? That's easy. All right, here's OPQRST. Now, O, everybody in this, all of our instructors will tell you O means something different. I don't know why this is so difficult. Okay? Some people will say onset's supposed to be what time did this start? No. Okay? Onset has nothing to do with time. Okay? Onset, your NREMT will follow this specifically. What were you doing when the pain started? Because time is how long ago did this start, not what were you doing when this happened. And I think this one even, no, this one does. I fixed it. Yep. No, because I don't think this is what P stands for. To me, is what makes it better or worse. This says what does anything trigger the pain? When you move, does that make the pain worse? That's more what provocation is asking. Okay? So O is onset. The question is, what were you doing when the pain started? Provocation, the P is, does anything trigger the pain? If you want to write down what makes the pain better or worse, if anything, that's also fine. It's like chest pain. You're having chest pain. I say, do I push on it? Does it make it better or worse? When you move, does it make it better or worse? When you take a deep breath, does it make it better or worse? That's all provocation stuff.
So, my question is that what they took out? They're lumping it all into one word. That's what it's about palpitation.
Yeah, we used to have two, but provocation is the best way. I think it depends on the textbook if they use the term palpitation or provocation.
But does it matter when it comes to the national text?
They won't give you both options. They're only going to give you one or the other. And I'll bet you they stick with provocation. Right, but palpitation meant something else when it came to OPQRST. The downfall, we've been using these acronyms for 25 years. This stuff has never changed. So quality, and the way I usually word this is, if you could use one word to describe the pain, what is that word? Right? Don't give them words. Okay? You tell me what it feels like to you. If you can pick one word to describe what you're feeling, and don't say if you can use one word to describe the pain, because if it's discomfort or something like that, that doesn't apply. Notice what word is in every single one of these. Pain. Right? Because truly OPQRST was meant for pain. We just found different ways of using it. Make sense? So quality is describe the pain, or if you could pick one word, describe to me the pain. Okay? I know this says region and relief. I want you to write down just radiate. Okay? Can you point to where the pain is, and does it seem to move anywhere? Okay? Radiate. Does the pain move? Okay? Again, what word is in all three of these? Pain. They say discomfort. Where is that discomfort? Does that discomfort seem to move anywhere? Okay, severity, on a scale of 1 to 10, 1 being no pain, 10 being the very worst pain of your life, what color is your pain? Just checking. They say green, they got it right. Good call. They say 8, you say you don't listen very well, do you? Okay, scale of 1 to 10, 1 being no pain, 10 being the very worst pain of your life, how bad is your pain? If they go, I want a number, right? Just ballpark. Do I dare ask you what your question is?
Well, I mean, I've seen a lot of people do like 10.
Right.
Talking to like you and I talking now.
But it's them telling you, right? So you might put that in your head. To me, now, how many of you have seen those pain charts in the hospital, right, with the smiley faces or not smiley faces? To me, 10 is like uncontrollably bawling, right? Like that's the only one on that scale that has tears, right? Your pain is different, or your 10 is different than my 10 versus your 10, right? I don't know why it is. Little old ladies are the toughest people I've ever met in my entire life, right? They'll have snapped femurs and no arms. They're like, on a scale of 1 to 10, 7, right? And the big tough wrestling kids got a dislocated finger. He's like, it's a 14. I'm like, wow, right? Good thing you wrestle. Just kidding. How many of you are wrestlers? I figured. That's all right. Whatever. All right, so scale of 1 to 10. 1 being no pain, 10 being the worst pain in your life. Time, when did the pain start? That's easy. That's OPQRST. No, not in this one. Oh, yeah. What were you doing when this pain started? No, I don't want to tell you. You gotta, right? I just want to write it down. I'm going to tell the story later. What were you doing when this pain started? What makes the pain better or worse? What does the pain feel like? Does the pain move? Scale of 1 to 10. Well, what time did this start? They use the word discomfort. Use the word discomfort. Can this be used for anaphylaxis? Sure. What were you doing when this anaphylaxis started? I got stung by a bee. Awesome. So does anything make that bee sting better or worse? You don't have to ask that question. Another bee sting. I haven't thought of that one. Right? The next one is, what does the pain feel like? A bee sting. Right? Does the bee sting radiate anywhere? Only if I get stung by another bee. On a scale of 1 to 10, 1 not being stung and 10 being 10 bee stings, where do you sit on this list? And how long ago this happened? Only a couple of those apply. Does that make sense? You can use them, but only a couple of them apply. Here's sample. Here's the other acronym, right? Symptoms, because signs is something that you measure, heart rate, that kind of stuff. So what are your symptoms? What are you feeling? Okay? Do you have any allergies? Do you take any medications? What is your past pertinent medical history? Okay? When's the last time you had something to eat? What were you doing when this started? Now notice that E and O are the exact same question. Okay? If you ask E before O, then just restate it in O. So you're telling me, so you told me you were mowing the lawn when this happened, and then you can just kind of pick it up from there. Right? The way I was taught this was we asked S and then OPQ or ST, because if they say I'm having chest pain, then OPQ or ST is to dive deeper into chest pain, right? The way I was taught was S, OPQ or ST, and then I went through ample. However it works for you, I don't care. If it works, figure it out and make it work for you. Okay? So sample, OPQ or ST. What is your symptoms? Do you have any allergies? Do you have any medications, and are you taking them like you're supposed to? Pertinent past medical history. When's the last time you had something to eat? What were you doing when this started? That's sample. We've killed sample, OPQRST, AVFU, CTC, Pearl. We've talked about MOI and NOI. We already talked about warm, pink, and dry. Right? We're going to get through more. Don't worry. You're killing me. You need more coffee, too. We've already talked about that. All right, so here's specific with pediatrics. Okay? Kids get on the same level, not mentally. This is like a physical thing, right? Kneel down. The last thing the 4-year-old wants is for, well, some of you won't boom over them, but someone booming over them. I didn't look at Michaela. Michaela, don't look at me. I didn't even look at you that time. 4'1". You don't want to be standing over them. Right? Kneel down. Right? Could they attack you? Yes. Okay? It could happen. But we kind of let our guard down with kids. Right? Put questions in simple languages. You start rambling things off like provocation, quality, and stuff, they're going to look at you like they always do, like, what? Right? Do you hurt? Point to where it hurts. That spot that it hurts, do you feel that hurt somewhere else in your body? Does that make sense? You're going to ask them on a scale of 1 to 10. They're not going to answer that. They're going to be like 17. Sure. Right? Gather as much information as you can from caregivers. What were they doing when this happened? Has this ever happened before? See what I'm saying? You got to use mom or dad or grandma, grandpa, caregiver, who, babysitter, whoever. Make sense? All right. Physical exams with your conscious medical patients are usually brief, and it's specific to the body areas. The areas we've talked about that you're going to palpate are specific to chief complaint, right? They say chest pain. Do you need to palpate their abdomen? Not necessarily. If they say, I'm having toe pain, do you need to palpate their spinal cord? Not necessarily, right? If they're unresponsive, would you palpate their entire body? Absolutely, right? Don't forget that little piece we've talked about on looking for medical alert jewelry, right? Especially unconscious patients. All right, notice the position. What? No problem. The last word's complaint. you wouldn't have taken my coffee cup, I wouldn't be so mean to you. And then you rubbed up my face. Now it's on like Donkey Kong. Good? Good thing. What position is this person in when they're listening to lung sounds? Okay, there's that, but they're just sitting up. Let's go with the broad version of that, okay? Okay? Do not, unless the patient is unconscious, do not listen to lung sounds with someone laying flat. Okay? It gives you an inaccurate sounds. Okay? So sitting up, the back is sometimes easier to hear than the front. You can do your preference. Right? If you can hear lung sounds just fine in the front, great, do it in the front. If you have a hard time, listen to the back. Okay? That's easy. We already talked about vitals. Forget that. We're just moving on. Look at that. All right. We just killed 3 slides in 3 seconds. That was a record. Unresponsive medical patient begins with physical exam and baseline vital signs. Okay? Airway, breathing, circulation, get a good set of vitals. Now, gather as much history as you can from bystanders or family members. What happened? What did you see? How long they've been here? How did you find them? Did you move them? Did they complain of something before they fell? Did they complain of something before they went unconscious? How have they been feeling the last couple of days? Okay? Those are all questions to ramble off to family and bystanders. Okay? Then you're going to do a rapid assessment of the entire body, all the way from the head to the toes, and including the back. We're going to talk about that here in just a second. Make sense? You guys are never going to come back. Notice how I wait until you can't get a 100% refund until I start talking about this chapter. Oh, yeah, you're past it. I think you're down to like 75%. Yeah. You made it this far. You might as well just hang on for the rest of the ride. You're, what, 4 weeks into this? What? It's only 3 weeks. I don't remember. It's only 13 chapters. 13 chapters and 120 slides. We're not done with 14 yet. There's 110 more slides. I'm just kidding. I don't know how many slides there are. All right. So the rapid assessment of the entire body, okay, is a head-to-toe physical exam for the trauma patient. We use the rapid head-to-toe exam on medical patients that are unconscious. You're going to systematically assess the head, the neck, the chest, the abdomen, the pelvis, the extremities, and the posterior. Okay? You're going to go from the head. You're going to work your way to the toes. You're going to roll them over. You're going to check their back. Okay? Now, this rapid head-to-toe physical exam, you're only looking for life threats. Make sense? That's easy. How long do you think your rapid head-to-toe exam takes? A little longer. 60 to 90 seconds. Okay? So that should be your goal. 1 minute. That, if you have 1 minute in mind, that will make you only worry about stuff that's life threats. Okay? You don't check for pupils in a rapid head-to-toe exam. You don't listen to lung sounds in a rapid head-to-toe exam. Okay? You palpate and you inspect. Head, eyes, ears, nose, throat, neck, chest, abdomen, pelvis, lower extremities, upper extremities on their back. Okay? Cut their clothes, run your hands. Go ahead, sir.
I think the answer is no, but there's a 95% chance they have a spinal injury, you still roll them over.
You do, but someone has to hold C-spine. Right? You roll them with C-spine in mind. Someone holds C-spine, you roll them over, you roll with the head, you roll them back. Good question. You still got to roll them, right? You just got to protect their spinal cord in the process. So full spinal mobilization technically is C-collar, headbed, and backboard, right? So this is all before you even put them on a backboard. Someone's holding manual stabilization, but it's not in full C-spine precautions. So one of the acronyms that's up there is HEENT. It stands for head, eyes, ears, nose, throat. Head, eyes, ears, nose, throat. Okay, when you're looking at the head, that's what you're looking at. Is the head intact? Do they have eyes? Is there any fluid coming from their ears? Any fluid coming from the nose? Any fluid coming from the mouth? That's the head. All done. Okay, now you're going to look at the neck. A couple different things. Is there JVD? Is there medical alert bracelets, or necklaces, I guess, in this case? And what is the trachea location? What you're looking for is dead center. What you don't want is what's called trachea deviation, which is that trachea being pushed to one side of the other, where it favors a lung. Right? So with the neck, is there JVD? What's the location of the trachea, and are there any jewelry? Make sense? Next comes chest. Okay? I know it says breath sounds. If you throw breath sounds into this, it can slow you down. If you can do this whole process and do lung sounds in 60 seconds, awesome. Right? That's going to take practice, I guarantee you. Make sense? Then comes abdomen. You're going to palpate all 4 quadrants. Is there distension, which means what? Swelling, which is an indication of blood or fluid. Right? So is it abnormally distended? Is it hard to the touch? And they're not a bodybuilder. Okay? Rigid is the same thing. So this is blood. What would be firmness? Could it be blood? Could it be an organ that's inflamed? Absolutely. Right? So neck, JVD, trachea deviation, medical or jewelry. Chest, you're going to palpate, inspect, you're going to auscultate. Abdomen, soft, non-tender in all 4 quadrants. Then comes pelvis. Okay? Are they incontinent of feces or urine? Okay? Then extremities. Now, there's 3 words up there. I should have an acronym I forgot to write down. Now, older acronym is PMS, standing for pulse, motor, sensation. Most of us have gone to CMS, which is circulation, motor, and sensation for obvious reasons. Okay? Pulse, motor, sensation. Okay? Basically, do you have a pulse? Can you move it? Can you feel it? Okay? You're going to do that in all 4 extremities. If you got a pulse, can you wiggle it? Can you move it? Or can you holy crap. Does it have a pulse? Can you move it? Can you feel it? The extremities, you're also going to look for medical identification devices. I like how it says it in red, and it says it again. That's how important it is. It says it twice. Again, if you can throw pupils in there in 60 seconds with your lung sounds and all of this, awesome. That's also going to take practice. Make sense? Yes. So just it replaces pulse with the word circulation. So head, eyes, ears, nose, throat, neck, chest, abdomen, pelvis, lower extremities, upper extremities, posterior. Make sense? So I don't know why the back's not here. So posterior, you're going to look for the normal stuff like bleeding, all that good stuff. You're also going to take your hand, you're going to finger walk the spinal cord from the base of their skull all the way down to the pelvis. What you're looking at is for deformities or step-overs or step-offs, right? You're finger walking the spinal cord, and all of a sudden the spinal cord's like an inch to one side, right? That's a pretty bad sign. Or you're finger walking the spinal cord, and you note the swelling. We call it like a dolphin fin. All of a sudden you note that your hands are pushing on swelling. They have a bulge on the spinal cord. Okay? We talked about that. Look, we can go past that. That's awesome. Get rid of that too. So questions to ask bystanders. You don't have to write this stuff down. It's pretty self-explanatory. Just think of the fact of they know something and you want to know it, so ask questions. Right? What's the patient's name? What happened? Did you see anything? Did they complain of anything? Do you know if they have any medical problems? Do you know if they have allergies? Do you know if they have medications? Does that make sense? You're just going to ask them a bunch of questions. Get your baseline information. Now, this needs to happen fairly fast, right? Wouldn't you say that all unresponsive patients are critical? You can go with that, right? All critical patients need to be going to the hospital as quick as possible, right? You don't get to take this person with you. So ask as many questions as you can, as quickly as you can. The best way, if we're a 4-person team, Brett, go ask some questions, right? You're doing something, we're doing something, we're all done. You can bring it back to us and go, here's what we know. This is John. He's 35 years old. He complained of chest pain before he collapsed, and they think he has a cardiac history. Awesome. It's more than we knew 10 seconds ago. right? But ask these questions quickly because you don't get to take that person with you, okay? The choice of taking a rider is always up to the ambulance crew, okay? I can say, you know what, Anthony, I don't want you in my ambulance, right? I don't care if the kid's 1 year old or the person's 100 years old. It's my choice whether or not you go. Parents who like, I'm their parent, I have to go. No, you don't. You get to go. There's a big difference, right? You're a problem. You're going to be a distraction. You're going to be a danger. You're not going. Make sense? Always falls on your ambulance providers. Looking for things. Anytime you have an MOI that suggests a spinal injury, you're going to hold C-spine and treat them accordingly. Make sense? This is the first time we literally brush over C-collars, and then it's like we're done, right? We're going to revisit neck injuries and stuff when we get into trauma. Okay? MOI that suggests a neck injury, hold C-spine. Now, initially, airway takes precedence over C-spine in some circumstances, right? Emergency moves are your priority. Okay? So think about that. So let's say your patient's unconscious and you have nobody to give you information. Does your patient's medication give you information about their past medical history? Yeah. Absolutely. Use it. Right? And it'll be cool because there'll be 100 of these. Right? And you're going to be like, I don't know what 99 of these mean. One of them's aspirin. I got that one. Right? There's a really cool app that's free. It goes on your smartphone. Those are phones that are more intelligent than you. And the app is called Epocrates. EPO Crates. Right? EPO Crates. C-R-A-T-E-S. Okay? It's a pharmaceutical app that allows you to look at the medication. You type in the medication, it tells you everything you know about it. What's it for? What happens if you overdose on it? What are its side effects? And if you have internet access, it gives you pictures of what the pill should look like. It also works backwards. You can take a pill and type in, is it scored? Is it clear? What color is it? Are there any markings on it? It will tell you what the pill is. Right? It's amazing. I use it on every single call, literally almost like without a doubt. A medication you never heard before? Look it up. What is it for? You will see that medication again, right? Build that database of stuff that sounds familiar, right? You get some, sketchy person who's got a bag full of meds. You can start looking through them. 5 of them are opiates. 2 of them are blood pressure medications they stole from somebody else. You know what I mean? Like you can look through them and be like, you know what? These are no big deal, but this is a problem. Make sense? Super, super good. It's free. You might as well download it, right? You will use it, I guarantee you. Mid-chapter review. Let's just skip that and move right on. So, secondary assessment of the trauma patient. That was medical. There's 4 mid-chapter reviews. And it's more like quarters, right? Quarter 1, quarter 2, then there's halftime, which we'll let it go home till Tuesday, and then we'll cover the other 2 quarters when we get back. All right. So this is the trauma stuff, right? I love this. Injuries range from slight to severe. Shocking, right? To determine how serious an injury is, consider where the injury is on the body, right? And what is their mental status. Their mental status by far is the biggest and first red flag you have for shock. If they're altered and you think of trauma, they're in shock. Number 1, right? You should pick up on this before you look at heart rate, blood pressure, respiratory rate, all that crap. Right? Mental status, number 1. Make sense? The next on the list, airway status. What are their vital signs? We talked about looking at their mechanism of injury and their patient's age or pre-existing conditions. Pediatrics and geriatrics should always be your biggest concern, right? Because trauma in those present totally different. Make sense? Also, do they have a high risk for cardiac or a high risk for stroke or a high risk for diabetes, something along those lines? Any trauma patient that's on a blood thinner, you need to treat as if it is a critical trauma. I literally mean a standing fall, right? If I was on blood thinners and right now my knee gave out and I hit the floor, there's a high risk something's wrong just because of the blood thinner. right? So keep that in mind. Let's see here. Chief complaint, we already talked about that. History of the present illness, this is the MOI stuff, right? What was the nature of the force? What direction was it in? Were they wearing protective equipment? We pretty much talked about all this stuff with MOI, right? This is nothing, should be nothing new. Okay, we're going to dive deeper into trauma, I promise you. So, 3 techniques for that rapid head and toe exam that we talked about. We talked about inspect. You can, I don't know why they put observation. I like inspect, palpate, and auscultate. Observation, palpate, and auscultate, whatever you want to think of. OPA, IPA, I don't care. That's a good one. IPA, beer. Right? I'm already thirsty. Yep, it'll work. Inspect, palpate, and auscultate. It's almost beer time. Where's my Nalgene bottle? Definitely. Okay, so 3 techniques of physical exam. Inspect, palpate, auscultate. The only thing that you auscultate in your rapid trauma is going to be lungs, right? We don't listen to heart tones. We don't listen to bowel tones, okay? As much as nursing students think that we do. Not that I'm picking. Look, it's a physical exam. Great. What you're looking for, right, in the inspection piece, you're going to look for abnormalities, okay, color, shape, and movement. That's easy. Inspect or observe means you look. Okay, use your eyes. You can't see it, uncover it. Okay, I work on ski patrol in the wintertime. One of the worst things that we have on the ski hill is the fact that we can't inspect very good on the ski hill, right? We don't expose injuries because the last thing you want to do to a trauma patient is put them in hypothermia. So the snowboarder, you know, who's not wearing a helmet, racks his chest and head on a rail. I can look at his head, but I'm not going to open his coat, cut his coat, and look at his chest, right? We treat and package on the hill, take him down to an aid room, and then unpackage, re-inspect, and then repackage and retreat, and then send to a hospital, right? Because you can't jeopardize heat loss for looking at something. They're critical, maybe. Make sense? Palpate, abnormalities in shape, temperature, texture, and sensation. Right? Can they feel? Can they move? Do they got a pulse? Is the extremity below the broken bone? Is it cold? That's a pretty bad sign that they're not getting circulation. Make sense? Pretty easy, pretty straightforward stuff. Notice how the stuff's not in red. I was nice for a few slides. It's still important. I just got tired of highlighting stuff in red. The red ink on my computer ran out. So auscultation, you want to listen to lung sounds. You want to know, are they decreased or are they absent? Those are both bad. Okay, you should hear air movement all the way through all lobes of your lungs. When we get into respiratory, we're going to teach you lung sounds. What the sounds are, how to do them, get a little better at that stuff. Okay, my goal for you when we send you off to your internships, your clinics, yeah, we're not rid of clinicals, internships, is good at vitals and great at assessments. I don't even care if you know how to treat people. I don't care. Okay, vitals, assessments. Okay, we'll work on the treatment stuff. Here's the other fun one. DCAP BTLS, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. Okay? When you do a rapid trauma, these are the things you're looking for. Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. That's literally how well you should know them. Okay? Deformities we talked about. What's a contusion? Bruise. What's an abrasion? Road rash, right? Small break in the skin. Punctures and penetrations, that's self-explanatory, I hope. Burns is a burn. Tenderness is your feeling, and they tell you that hurts. Lacerations is a cut. Swelling is swelling. So we talked about head, eyes, ears, nose, throat. We talked about neck, JVD, trachea deviation. We talked about palpating the chest. We talked about lung sounds. We talked about soft non-tender in all 4 quadrants of the abdomen. We talked about pelvis. We talked about all that stuff. This is the other piece that you're looking for, right? deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. Make sense? Now, you can write a note card with DCAP VTLS. That's good. Okay? I encourage you to make a note card for each individual letter. Because unless you know what each letter means, you can ramble on, because you might say, I'm going to look for DCAP VTLS, and I go, oh yeah? What's it mean? Right? I don't care that you can spell it. I want you to know what you're actually looking for. Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. What are you looking at? What? Yeah, from this far away? It'd be impressive. Kind of weird. Typical District 10. So much fun. I had to deal with like Johnny Waller and all those guys, right? You guys are getting the end of my patience. Don't I want to tell you I duct taped his hands to his head, middle of class? He's mouthing off, leaning back in his chair, and I had a roll of duct tape in my hand. So I pulled the duct tape, got him across the forehead, got him both of his hands, and just undid the entire roll of duct tape. Head, eyes, mouth, nose, everything. Johnny Waller. Yeah, duct tape the hell out of him. It was awesome. I was like proud. I wish that was the time when I recorded stuff. I'd watch it every day if I got sad. All right, physical exam, then vital signs, right? This is all the same stuff. Is sample important with a trauma patient? Absolutely. Right? If they're unconscious, you're not going to get sample. But it's still important. Allergies, maybe not so much. Medications, though, right? Because are they on aspirin? Are they on blood thinners? Those things are important. Past medical history could be important. Why is last oral intake important with trauma? What if they go to surgery? One of the questions they're going to ask, when's the last time you had something to eat? Or in trauma, nausea and vomiting is a sign and symptom of trauma. If they're going to puke, you want to know, is it going to have stomach contents in it or not? Right? Events leading up to is pretty easy. What were you doing when this trauma happened? Were you, how fast were you driving? Were you paying attention? Stuff along those lines. Look, sample again. It's not in red this time. Okay? If there's an MOI that suggests they have a spinal injury, then you're going to put on a C-collar. Okay? This is that just, we're going to like glance over it, we're going to move on. Right? Because we're going to beat, who the hell is that? Is it an active shooter? Hide. Who is that? What do they look like? Oh, it's Ross. What's up? What are you doing? Nothing. This is Ross. You want to tell about yourself real quick? 30 seconds. You want to know our evaluator. 30 seconds. Go.
I'm Ross. I haven't been here for very long. You may have seen me around a little bit doing ELF construction or ACLS stuff.
What level of care are you?
What?
What level of care are you?
Paramedic.
Where do you work?
With AMR, and I'm in nursing school right now, and here.
How long have you been a paramedic? How long have you been a paramedic?
2012.
Perfect. I was looking for like a number of years, but that's fine. Me neither. We just had this conversation. Have a great day. Drive safe. That was easy. That's a C-collar. We're going to talk about it later. Look, that's a C-collar. That's how you measure it. That's a C-collar. Yeah. Massage with all 4 fingers. Right? You want to catch all that plaque. All right. Once you apply the C-collar, right, you're going to size it. You're going to remove jewelry and remove hair. If they've got a lot of hair, you just cut it off. See how that looks like it's been cut? Easy. If it's in a ponytail, and just give it to them here just in case you want it for a wig or something. Just kidding. We're going to talk about that more later. Don't worry. So here's the big one everyone forgets. Your C-collar alone is not the definition of immobilization, right? If you put a C-collar on, you still have to hold C-spine. The only way you get to let go is if they're on a backboard with a headbed and strapped down. Which still provides that stabilization, right? Yeah. Coffee Cup's got intelligent powers. He's going to get duct tape before this class is over. He's smart by sitting in the middle. Takes longer to get him. So here's pictures, right? So what does it look like he's doing besides something weird? Yeah, checking his head for blood, right? How many of you have had like a head laceration or seen a head laceration? Okay, besides Adam, how many of you know what it looks like to have blood in your hair? Bald. It's a bald joke. Sorry, Adam. Oh, you're bald too, but you're wearing a hat. Good call. Right? It's hard to see. So run your hands through their hair, then look at your hands. Right? If there's blood, they're bleeding somewhere. Okay? Rapid head toe assessment, we talked about this, right? Palpate cranium, face, eyes, ears, nose, mouth. If there's blood or something in their mouth, clear it. Okay? Look at the neck. You're looking for decap VTLS. You're looking for trachea deviation. You're looking for JVD. Yeah, so that's basically just, that's just a reminder of what all you're supposed to look at for the head. Head, eyes, ears, nose, and throat. That's easy. Okay, look, listen to lung sounds. Check on the chest. Okay? Looks like a big lump right here. I'm not really sure what the hell's going on. I think it's just a shadow, but it looks like a big, nasty bump. Let's see here. Talked about these. All right, so we're all mature adults, right? Most of us. So the term right here is priapism. Okay? This is an erection that's caused by a spinal injury. Okay? So the downfall with this, all of you mature adults besides that row, clearly, this right here means you will be paralyzed for the rest of your life. Right? Let's work on our professionalism because it is graded. Okay? So spinal injury-wise, can they feel? Can they move it? Do they have pulses? Okay? If you find priapism, you note it because the hospital will want to know. It is an indicative sign that they have a severed spinal cord. Right? I will tell you that is one, they'll never ever have feeling below. Usually it's about belly button is where the dermatome actually is. Right? Paraplegic, guaranteed. No, usually, like I said, it's below the belly button line is where it usually produces a priapism. Right? High up it might, but usually it's that real low spinal injury, right? Like lumbar spinal injury. Okay? When you palpate the spinal cord, these will almost always have that step off or step over. Right? Because it's not a spinal fracture, it's a severing of the spinal cord itself. Yeah, so like the spinal cord's off to one side, or you can tell like an obvious drop. Okay? Abdomen, we're going to talk about assessing the abdomen once we get into abdominal. When you check the back, roll them on their side, assess. We talked about using spinal precautions with that. Right? This is them finger walking spinal cord. Now, if you put the C-collar on, you just got to finger walk from that point down. That make sense? General principles, expose injury area before examining it. The maintain eye contact thing, I don't know what the reasoning is. That's weird. Assume spinal injury, stop or alter assessment process to provide care. You find a life-threatening problem, stop, fix it, and then move on. Stop. 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 I knew that's where this was going. That's circulation. That's movement. That's strength or sensation. That's easy. Adam, you okay over there, bud? We talked about pediatrics. Detailed physical exam. Groaning is amazing. All right, so you had your rapid trauma, right, which took you how long? 60 to 90 seconds. Your detailed physical exam is identical to the same stuff. It just takes you longer because you're more in depth. That makes sense? The key to this is normally done en route. You never, ever withhold transport to do a detailed physical exam. Okay? Rapid head toe. Head, eyes, ears, nose, throat, neck, chest, abdomen, pelvis, lower extremities, upper extremities, and back. Okay? 60 seconds. Now, you're transporting, and you want to go back and find those secondary non-life-threatening problems. So you start back over. Head, Real good assessment, right? Feel, look for blood, look in the hair, eyes, check for pupils, feel the eye sockets, feel the cheekbones, look to see if they're missing teeth, feel their jaw, look at their, it's just nice and slow. Go ahead, Libby.
Figure transport's really short. I know we're going to go over the whole ankle organ stuff.
Mm-hmm.
But don't get like halfway through that.
You may never get to a detailed exam. Yeah, short transports, you may never get to one. But rapid trauma happens in your primary assessment, basically, right? Because it takes you 60 seconds. Airway, breathing, circulation, vitals, rapid trauma, right? You got 10 minutes on scene. That's your goal. You can do all of that in 10 minutes. Make sense? Whoops. We've talked about that. Talked about that stuff. Exposed patient, right? If you haven't cut closed, now's a good time, right? Spend a little more time, a little more detail, a little more focused. So here's the downfall, right? If you've backboard and ceased by them, you have to work around all that immobilization equipment, right? Each one of the straps, there's a C-collar, there's a headbed, there might be bandages, there might be, gauze, all that stuff you got to work around. Because you provided life-saving treatments, now you're just kind of going back through and managing those secondary or even third priority injuries. Make sense? So trauma patients who are not seriously injured, okay, rolls an ankle playing soccer, okay, do they need a rapid head and toe exam? No, right? So then you would never do a detailed physical exam. Almost always those are going to go hand in hand. So just be conscious of that injury. You would check CMS. You would check if there's any bleeding, but it'd be isolated to that rolling of the ankle. Does that make sense? So not seriously injured, then you're not going to worry about those rapid head-to-toe exams and those detailed physical exams. Make sense? Mid-chapter review again. Here's reassessment. Here's the nice thing about reassessment. I actually might get through this by 10 o'clock. It'll be a miracle. Reassessment, you start all the way back over at your ABCs and just start over again, right? Relook at airway. Relook at breathing. Is it still adequate? Is it not adequate? Is your oxygen doing better, right? Now's where you look. If my oxygen saturations have gone up and stayed at 95%, reevaluate the need for oxygen. Make sense? Look at circulation. Look at skin color. Relook at your vital signs. Relook at your treatments. Redo an assessment if you need to. Make sense? Reassessment really should be one slide of this that just says you're going to start all over again. Okay? You're looking for changes, whether they're subtle or profound. You're looking for trending. And really you've got three options. Are they getting better? Are they getting worse? Have they not changed? Okay? You're looking for deterioration. You're looking for improvement. That's easy. Getting better, getting worse. Talked about all that. What I want to get to is right. Literally takes slides to tell you to reassess. This right here. Okay? Critical patients every 5 minutes. Non-critical patients every 15 minutes. Make sense? Vince, the only thing you missed, reassessment, start back over at the beginning at airway. Work your way back to the whole process again. Airway, breathing, circulation, vitals, assessments, treatments, all that good stuff. You're going to do this every 5 minutes if they're unstable, every 15 minutes if they're considered to be stable. Make sense? Mid-chapter review. We're literally almost done, I promise you. How many what? I don't know. It's like I said, I think it's quarters. Okay? So here's critical thinking decision making. So here's what I'm going to tell you. This is my caveat before I start telling you how to diagnose. You never diagnose in the field. Okay? Every time you diagnose in the field, it always comes back and bites you. Always. Okay? You'll walk into a hospital and feel like you're a rock star, and you'll tell the doc, I know for a fact this is a stroke. And he'll go, guess what? we found out it was cancer. Didn't see that coming, right? You'd be like, listen, I did a really good assessment. I'm the best EMT in the city. I know for a fact this is a heart attack. And he'll go, actually, it wasn't a heart attack.
Have you ever accidentally done that?
Oh, all the friggin' time. We misdiagnose all the time, right? That's why we shouldn't diagnose. Your job is to not diagnose. On the NREMT, they're going to want you to diagnose. In this class, I'm going to expect you to diagnose to a certain point, okay? Because this is like one of those like mushy things. I think you're better than that. Because people are like, well, you're just an EMT. BS, right? You should have a pretty darn good idea if you spend time with patients, what's wrong with them. At least have a list, right? You should never get to a hospital and be like, I have no idea what's wrong with them. Your answer would be, I know for a fact they're not hypoglycemic, they're not hypoxic, they're not hypothermic. It's all you for that, right? Because those are the things you can look for. Make sense? Libby, go ahead. Because for the longest time, that's all you were, right? The education was horrible, right? I will tell you there's other programs, I'm not going to pick on programs, that I wouldn't work with the EMTs that come out of some programs in the city, without a doubt in my mind, no way. There's a program in the city that has a passing rate of less than 20% on the NREMT, right? I don't want you working on my family. And that's what I expect of you in this class. You will only pass this class if I think that you'll take care of one of my daughter, my wife, right? Learn this stuff. Learn what is in a diagnosis. You don't have to diagnose, but at least have a good idea, right? Because you're intelligent. You can read, most of you, right? You can research. You can learn. It's all there. You just got to do it yourself, right? There's a ton of the stuff in this class that I teach you don't need to know. End-tidal CO2 has nothing to do with your textbook, right? I called my medical director and said, hey, I'm going to teach end-tidal CO2. And he was like, thank God someone's finally teaching EMTs that, right? We're going to go above and beyond what you need to know because that's where you should be, right? So diagnosis is a label, okay? We're going to talk about the term differential diagnosis here in a second because that's the term you're going to hear me say a million times before this class is over. So how clinicians reach a diagnosis is, for one, they go to school a hell of a lot longer than you will, right? They're doctors for a reason. Now, the word doctor kind of gets thrown around a little bit, right? I've had people who show up on car wrecks, massive trauma, are like, I'm a doctor, can I help? And I just go, what kind of doctor are you? Well, I'm a podiatrist. Cool. Grab a stop sign, direct traffic, right? Because your specialty of the foot has nothing to do with this massive trauma. Right? You're a dentist, awesome. If I break a tooth, I'll come see you. Right? You're an ophthalmologist or ophthalmologist, whatever, awesome. Right? When I need new glasses, I'll come see you. They have specialties. They have unique things they're good at. Right? Your ER physicians you'll come in contact with are amazing people. Right? Usually come across as arrogant, pompous jerks. If you ever get one to talk to you, just start asking questions. Right? You're in a hospital and you happen to have a doc who's like, hey, what do you think is going on with this patient? You're like, I know it's not diabetes. What do you think is going on with this patient? Right? Listen and let him talk to you because it doesn't happen very often. I really, really promise you that. Right? So the term differential diagnosis, write down that term. Okay? Differential diagnosis is defined as list of conditions. That's what I'm going to expect of you in this class. Every single scenario that you do and every single report that you write, you're going to give me a differential diagnosis. And what I expect of you is every single chief complaint or assessment reveals at least 5 things you think is wrong. Okay? Derek's going to work through a scenario the patient's having chest pain, right? He asks the good questions, how long has this been going on, whatever. He gets done with sampling opioid accuracy. I'm going to stop him and say, hey, Derek, what are 5 things you think is wrong with this person? Right? And he's going to ramble off 5 things. I think it's a heart attack. I think it's heartburn. I think it's pneumonia. I think he's got a spontaneous pneumothorax. I think he's broke a rib. Right? Are 4 of those wrong? Absolutely. The purpose of differential diagnosis is, I'm going to go to the whiteboard. Get ready. It's going to get ugly. If I ask you what's one thing that's wrong with somebody, and you say MI, what do you think about the entire time? That's it, right? This is the stroke patient who's a diabetic, right? If that person, I would tell you, they told me it was a stroke, and I walked in the door and said, I know for a fact this is a stroke. That's all I thought about, right? So let's use that as an example. Let's use that one. CVA means stroke. We'll talk about it later. If I would have walked in that house and said, I want 5 things this could be, being altered, I would have said, I think this is hypoglycemia. I think this is hypoxia. I think this is a stroke. I think this is a mini stroke. We'll talk about that term later. And I think this is hypothermia. Now what does it make me do? It makes me narrow it down. So differential diagnosis, I'm going to stop Derek and say, wow, give me 5 things. Now, all of your questions from that point on is to narrow down these 5 things to a list of 3. And then I want a list of 2, and then maybe you get to a diagnosis, right? Had I would have done this, and number 1 needs to be your biggest life-threatening problem, right? That's your biggest concern. At that point, I really don't care where you put severity. If I'd have walked into that lady's house and said, I think it's hypoglycemia, hypoxia, stroke, mini stroke, or hypothermia, I would have stopped and said, what's her glucose? It's 21. Problem solved, right? Let's say I put this down here. Okay, I'm going to check her body temperature, 98.6 degrees, right? Do a stroke scale. She's positive on the stroke scale. That's got to stay there. Her saturation is 98%, right? Now it's stroke and diabetes. What's her glucose? 21. See what I'm saying? So not only will you do this on every single call, then your reports, we'll talk about it on Tuesday, every one of your reports you do, your 5 patient contacts you do in the field, I want to know the 5 things you were thinking about on every single one of those patients. Okay? I will tell you the one diagnosis I will never take is seizure. Why? It's not a diagnosis. What causes seizures? Hypoxia, hypothermia, hypoglycemia, drugs, toxins, cardiovascular problems, epilepsy. See what I'm saying? This is not a diagnosis. This itself has 10 things underneath it.
So that's like a sign.
So kind of, you can call it a sign or a symptom, right? But that's exactly what it is. Okay? Don't use seizure. Okay? Use specifics. I think it's a hypoglycemic problem that's causing them to seize. I think they took a drug that's causing them to seize. I think they're hypoxic that's causing them to seize. Does that make sense? Yeah, epilepsy, that truly is just seizures, right? It's the medical condition that causes seizures. We can't diagnose that in the field because they got to go to the hospital. They got to get all these tests to rule out all these other possible causes of seizures. Still doesn't matter. You still got to rule out hypoxia, hypoglycemia. What's the number 1 cause of seizure in kids? Temperature. Right? Always. Number 1 cause for kids and seizures.
Which way?
High. Yeah. And the misconception is it's not how high, it's how fast it goes from point A to point B. Right? So my daughter a month ago had a temperature of 104.9. Right? That's a damn high temperature. Right? And the whole time we're like thinking to ourselves, what happens if she seizes while she's sleeping? EMS providers as parents is the worst idea ever, right? Because I can think of like SIDS and all kinds of stuff, so I'm like standing over her crib watching her breathe. And that for the first month that she was alive, right? It's terrifying. My thought process was if she's already that high, the chances of her getting high enough to seize is pretty unlikely. Now, we'd have caught temperature at 101, and then she went to 100. What happens is they're like 101, and all of a sudden they go to 104, their brain just restarts. That's all seizures is holding the power button on your phone for 10 seconds. It's a hard restart, right? Your brain fires on both sides, and your brain's like, nope, and shuts off, right? So what happens? You hit the ground, right, if you're standing, your body shakes, and then your body has to restart, right? It has to load all of its programs, which is why your breathing's weird in the beginning, then your heart rate's weird, and then your respiratory rate gets a little bit better, then you start to be able to talk, then you start to get vision, right? It's just a hard restart. It has to reload all those programs. So that's all seizures are, but there's got to be a cause, right? There's always an underlying cause. People don't just seize for no reason, right? Unless they're epileptic. And the number one reason why adults seize is not taking their epileptic medication, right? You miss one dose and they seize, right? That's all it takes. Because you built like this therapeutic level of drug, you miss it once, and literally within an hour they'll be seizing, almost every single time. It's pretty crazy how quick that happens. Pick up on red flags. So when you're reading your textbook, right, next week, try to think, probably not next week after next, we're going to start getting into body systems, like in-depth, right, respiratory and so on. I want you to build differential diagnoses in your textbook, right? I don't want you to think of the cardiovascular problem. I want you to think, okay, MI, what are all the signs and symptoms that create with MI? That makes sense? CHF, what are all the signs and symptoms? Because that's how the patients are like Jeopardy. They give you the answer, and you have to think of the question, right? They tell you, I'm having all these signs and symptoms. You have to tell them the condition. So you're thinking of it backwards, so learn it backwards. If the patient says chest pain, what are all the things that it possibly could be? If they say tearing chest pain, what are all the things it possibly could be? Does that make sense? Now, in your career, right, in this class, in your internships, in your career, you're going to build red flag lists, right? Things that you find. Patient says, I'm having tearing abdominal pain. That's a red flag for a dissecting aortic aneurysm. If you don't know that, the first time it happens and your patients die, I guarantee that red flag goes in your head. And the next time someone says, man, I got this tearing feeling in my stomach, dissecting aortic aneurysm. Right? Does that make sense? Then you start building questions to ask. You can go more in depth. Sample and OPQRST make you very close-minded. Because if I just teach you sample and OPQRST, I've just convinced you that those however many questions is all you need to ask a patient. Are there 100 other questions you could ask people besides sample and OPQRST? So learn what those questions are. If a paramedic is talking, shut your mouth and open your ears. Right? Don't waste your time of BSing with the other firefighter when the paramedic's talking. Listen to the questions they're asking, and then when they're all done and it's just you and the paramedic, hey, why did you ask that question about the patient's got CHF? Why did you ask them if they spent the last 2 or 3 days sleeping in a recliner? Because the CHF gets worse, they feel like they're drowning if they're laying flat, so most patients will sleep in a recliner until they now have progressive difficulty breathing, and now they've called 911. You log that, you ask the next patient, the patient thinks you are a genius. Right? You look like a educated EMS provider. Right? All these things, you don't know everything when you come out of this class, that's fine. You got to still learn though, right? What's that? Yep. EMS approach to diagnosis. So the downfall is we get a little bit worried about like the next call, right? We also have to work in an uncontrolled environment. There's a T-shirt floating around that people buy that says EMS doing the same shit as doctors at 60 miles an hour, right? Because we're expected to do that. People call 911 with the expectation that you're a medical professional, right? All the time, people, be like, hey, you know what? Here's what's going on. They go, well, you tell me. Do you think I should go to the hospital? And you go, that's not my choice. Why not? You're a paramedic, right? No, I'm an EMT. What's an EMT? You're right. My bad, right? It's just an ambulance driver. Then you would understand me, right? They don't know. They don't know what an EMT is or an advanced EMT or a paramedic. They don't know the difference, right? You're either all medics or you're all ambulance drivers. The public has no idea what your level of care means, right? So, and me and Jack have the same opinion. When I introduce myself at a hospital, I never tell a nurse my level of care. Because the second you say, I'm an EMT, they automatically think you're an idiot because you're not a paramedic. But if you go to them, when you get to the hospital and be like, hey, this is Anthony. He's a 27-year-old male. He's having some chest pain. We did an EKG and ruled out any MI. We've done a saturation, we've done a glucose. You feed them all of that, and they just think you're an educated EMS provider. They don't need to know your level of care up until they say, why didn't you start an IV? That's not within my scope of practice. Oh, Mr. Gus. Hey, buddy. What? Oh, I have your ID card that has your card access. That's cool. Okay. Educate yourself. Go to conferences. Can you as EMTs go sit in a paramedic refresher course? Yep. Can you take ACLS? Absolutely. Right? Can you go to conferences that are meant for advanced EMTs and paramedics? Sure. Learn something. Right? It's cool. The stuff they do is pretty awesome. Hi. I was going to be talking smack, but I forgot you were here. So, number one on your differential diagnosis, number one is your most life-threatening problem. Right? All 5 of those, start ruling them out. Okay? Now, be careful. In some of those, you can never rule out. If you put MI, heart attack, on your list, can you rule out heart attack?
Nope.
It's impossible, right? Even they have pain that changes with palpation, pain that changes with respiration, pain that changes with movement, and the EKG says they're not having a heart attack, 40% of the people will still have a heart attack because your EKG is not 100%. Can they have a negative stroke scale, right? No arm droop, no facial droop, no slurred speech, and still be having a stroke? Yep, fast exam only catches about 60 to 70% of strokes, right? So know the things that you can never rule out, but know the things that you can. Hypoxia, hypovolemia, hypoglycemia, hyperthermia, right? All those things you can rule out because you can adequately determine that that's not the problem. We'll talk about that stuff later. The big thing is that strong foundation of knowledge. How many of you are on social media? Right? Most of the class. Right? I encourage you, go start liking EMS pages. Right? EMS 1, GEMS, EMS World. Right? There's one called EMTs and Paramedics. There's some fun ones you can get that are like rated R. Right? Like really Bougie Brothers. I almost forgot about that one. Yeah, don't worry. It's one of the ones that I run. We have just started this. It's really dumb, right? I encourage you to like it on Facebook and see the dumb crap we come up with. It's pretty fun, right? Learn that stuff. All the articles that I'm telling you about, I'm finding on social media, right? I hit save. I come to work. I print them off. I read them. They got great stuff. EMS 1 and GEMS and EMS Word are probably the 3 best websites you can find for EMS stuff, right? Great, great stuff. Leadership and teamwork we're going to revisit, right? The biggest thing is you don't want to look like we don't know what we're doing, right? How many of you don't like looking like you have no idea what you're doing?
I work for the fire department.
Yeah. You're a wildland firefighter. Happens all the time, right? In this class, you're going to learn to be a leader. How many of you are shy people, don't like to talk to people? I know who you are, right? You're going to have to get over it, right? If you don't like meeting new people, EMS is probably not the job for you. Because every shift, you're going to meet someone you don't know. And you're going to have to talk to them and ask questions. Right? So, the arrogance, right, makes situations safer for everyone. Don't be confrontational. You have a problem with somebody, tell them. Right? Praise in public, punish in private. Right? Not physically, of course. Okay, manage your own tendency to overreact. Anybody here want to admit to the fact they overreact about stuff? I like it, right? Put yourself in their shoes. If your leader in your group screws up and you jump down their throat, I guarantee you'll screw up in the next scenario, right? Because put yourselves in their shoes. They have to lead 4 other EMTs, and they're going to screw up, okay? I'm going to do scenarios that on purpose will fluster all of you because you're going to have patients who die, right? You're going to have patients, stuff goes wrong. You're going to have patients who you make a mistake and something bad happens to the patient, right? Our job as evaluators is to pick up on that, you doing it in the classroom. You give nitro to a patient without checking a blood pressure, we're going to make sure that patient goes unconscious and stops breathing, right? And then they're going to die and say, you know what? Now I want you to talk to me like I'm their family and explain to me that this person is dead. And you're going to walk through that. I'm going to go, okay, you did something that caused their life to end. Now your medical director wants you to write an incident report of why that patient died. Right? Because if you do it in the field, that's what's going to happen. We want you to screw up in here, and we'll fix it so you don't screw up out there. Here you don't get sued. There you get sued. Right? Oh, my God, it's almost done. Right? This is the other one. I will be totally honest with you. I can deal with arrogance. Right? There may be people in this classroom I was warned that are arrogant. Maybe there isn't. I don't know. Right? Arrogance is an easy attitude to deal with. I can knock down arrogance. Right? The attitude I will not let you pass with is the attitude of entitlement. If you think you deserve to be in this class because you work for a fire department, so I'm not picking on fire guys this time and this time only, right? Normally I am. But if you think you deserve to be here because you work for City Fire or Valley Fire or D10 or whatever, you're totally wrong, right? You have to want to be here, right? You have to want to learn, okay? The other one is I don't want to hear you complain, okay? You make mistakes, who cares? I don't want to hear you be like, oh, I screwed up. Don't let me be the leader. I just kill people. Shut up. Right? We all make mistakes. Learn from it. Don't let it happen again. Make sense? It's over. 3 minutes. All right, here's the deal for, oh, that's just the mid-chapter review. I'm just kidding. All right, here's the deal for Tuesday. Okay? First, you have homework due of all the stuff you learned this week. Okay? Learn your acronyms, right? Kill trees, make flashcards. Okay? Also, we're going to cover communication and documentation. All of you should have got an email today from FISDAP that is your FISDAP access. Okay? If you didn't get one, check your junk mail box because sometimes it goes there. You need to create your FISDAP account. Okay? Tuesday, create it. By Tuesday, what I meant. If you got problems, email me. If not, get out of my classroom. I don't want to see you anymore.